Yeah, we can see you. Welcome back, viewers. We are in the second segment now. Usually the second segment is usually just an addition to the first one, just in case there's a certain portion that you want to cover. It's usually somewhere between, sometimes runs between 20 to 45 minutes. We try not to go beyond the 45 minutes just because then, it's an additional section that the viewers have to go through. But most of the time it's informative. It's value that we provide in there. So in this segment, Dr. Soman, we just want to cover your research. We want to cover research in Zimbabwe in general. I do know that everyone, or at least most professionals in the southern area, are complaining that there's not enough research being produced by paramedics within the pre-hospital setting. And as Malusi has mentioned earlier in our discussion, is that the universities are the ones that are responsible for producing or sort of like perpetuating that process of producing papers, because then they have a research department that facilitates this whole process. So perhaps we do know that you did a retrospective study on EMS utilization in Harare. Can you just chat us through what led to the study and what did you find?
Okay, thank you, brother. So remember, we've already spoken about when City of Harare EMS started and when it got professional and what happened from the huge turnover in terms of numbers of conveyances per day to what was currently obtaining during my time as a result of a myriad of factors. So in 2018, we managed to get in touch with Dr. Muchatuta. She was an assistant professor in America, very much passionate about emergency medicine. And to her credit, she also managed to link up with us and express how pre-hospital emergency care is a significant component of emergency medicine matrix. So she asked me a very simple question. If we can ask you to describe what has been happening with the city. I'm not talking about the numbers. I'm not talking about anything. Just talking about what have you done? What cause, from where, who is being transported? What are the the data completion rates? What are the outcomes? To my chagrin, I almost failed to answer because I didn't have that information. Yet I was calling myself the head of EMS services for Harare. I then said, okay, what can we do? Can we have a retrospective study? But I think we can make it worthwhile and quite impactful if we work together. So, to her credit, being experienced in emergency medicine research, coming from a culture that is rich in conducting strong, valid research, she managed to speak to her team in America, and we were all delighted when they actually paid a visit. Was before that, she had just presented alone. We had an open discussion as Zimbabweans. Her parents are staying in Zimbabwe, so for her she was more like interested because she said, if my mother happens to be in an emergency situation, where is she going to get help? How do we know that it's functional? How do you know that you can respond? Do you record such things? I said, yes, we can record. Are you free for us to then have a paper where we can analyze, look at it, what's already been done before we start to look about the future? So for me, it was interesting and I felt quite challenged. Remember, that's when I said, why have I not been doing this, even doing surveys, just to try and describe what we are doing? So she managed to convince me. Then the next visit, she brought her professors with her, two of them, I think. And we sat in our office. We started to look at our raw data for the patient care records. So we looked at them. We didn't change anything. We just said, okay, we are going to go, jump in, look at them. But because there were just too many care records, we had to define a time frame. So we thought for us to make it feasible, also objective, maybe let's look at a period of 14 months. So we went back 14 months. And I'm happy to say they provided the funding to our research assistants. They provided the tablets that we were now entering the raw data into for easier analysis. They provided the statistical analysis package from their university, the Red Cap, which made our life easier. So basically our research assistants, there were three of them. They were experienced EMTs. We just wanted them to upload the raw data into the tablets for ease of analysis when the time to do that came. So it was quite an exciting period because by just going into the records as an EMS head, I could tell just from observation that there are things that I should have been looking at that I was not doing. Some forms were not complete, some forms were complete, some you couldn't tell whether things were going east or to west or north or south. But we said, no, we are willing to enter everything. For us to have a realistic picture, we should be able to mouth that sour taste that comes in when you notice you are the head, but you're also not doing your job. But I was now interested in finding out more. So yes, it was a retrospective study. We looked at almost 1,000 records, and an interesting picture then came out that showed us that yes, we had very few ambulances compared to certain point in time. We knew, of course, we could do more, but we also found out that we are also impacting positively because the majority of our users, gravid mothers who are being transferred from clinics. Hospital of Harare is with about 45 clinics. So if there are not complicated cases, they deliver at the clinic level. But if they are in trouble, if there's an emergency that requires them to seek superior medical care or intervention, we then are there to transfer them to central hospitals or other private hospitals if they can afford. So by virtue of them seeking their first maternity services at a local clinic, you can tell generally that they are not from echelons of society. They are from, what people consider clinic services as, they're not for the rich, all those things. But so it means they can't afford the private hospital, private ambulances. Was for private ambulances, we are talking of an upward of $80 per conveyance, which is a lot of money in Zimbabwe. Maybe equivalent of 1,600 rand in South Africa. So for the majority of our people, that's a lot of money. It can be enough to buy a family basket for 3 weeks or 2 weeks. So the majority of our users were interfacility transfer. That's saying from a clinic to a central hospital, our data did not really look at the disaggregated data of or what were the different, reasons for their transfer, because that's a different research on its own. But of course, we knew the bigger proportion of those mothers of the issues were to do with hemorrhage during pregnancy, which is the leading cause of death amongst African women during pregnancy. So that constituted about 58%, 57%. Then the second group, it was the trauma cases, talking of trauma from vehicle crashes. So at the moment, road users, if they're using public transport, they are covered by the public transport operators. But the private ambulances, they were yet to have mechanisms to tap into that insurance for them to get paid. So when there's a bus accident within the vicinity of Harare, the majority of the response is done by public services because they don't demand cash upfront. But if they get reassurances from either bus owners, then they can come, or if they have mechanisms to follow up with the passenger insurance that is provided by the public transport people, then they will respond. So that's why the bigger proportion of the people we looked at, they were from the trauma cases, and majority of the trauma cases were from vehicle crashes. So this also helped us to look at what is really happening, how many accidents happened, how many people were conveyed. We also then looked at sort of like scoped in to see if as a city with this number of ambulances, we are conveying this so much people. So how many are being left out? Are we able to improve on this number? Definitely, you can't hope for more people to have accidents, but you can only prepare to respond in case they have vehicle crashes. So how can you then prepare, objectively communicate with our private counterparts? So we obviously needed to share some of the findings that if this constitutes 40-something% of our conveyance as a public ambulance, what proportion can you guys also handle during, accidents or vehicle crashes? So that actually led us to have a broader interactions with our private EMS providers. But as a city, it was obvious that we could see the huge gaps that we can actually improve on, not just the number of ambulances, but also patient outcomes. We could also improve on our records, completeness, timeliness, and also patient outcome follow-up. Because there's a tendency to then convey your patients, but on our records, we didn't have that component where if we convey 100 pregnant women who are considered an emergency, we didn't have the mechanisms to then go back to where we conveyed them and then get the outcomes. Did they make it? Did they die? What was the outcome of the pregnancy? Did the child or the neonate die, or did they make it? So it would also then speak into the national indicators. We're talking of maternal mortality, perinatal mortality, neonatal mortality, all those things. So as a province, we should then be able to tally and understand the trends within the provincial indicators. Are we helping to improve, or we're actually worsening by not having many ambulances, or we are still where we were when we had 48 ambulances. But we don't know that because we didn't analyze that data. So it was quite challenging, and we are very grateful to our American, colleagues for funding that research.
I was wondering here.
For now, unless if you have questions, so that I then go to the findings that are quite specific.
Yeah, I was wondering. Sorry, Elias. On the retrospective study that you did, there were 875 PCRs, and you have said that that was in 14 months. Was there an exclusion criteria for others that were not included in the study? Because if I look at it in that way, it means that there were like 2 patients per day in the period of 14 months. Were others excluded, or it's because they were not completed that they were not included in the study?
Yeah, I was gonna say that I'm sure you see more patients in a day than more than 2 in a population of 3 million. If you take it into proportion to how many people you cater for versus what you accounted for in your research.
So, on average, that may be the case. We're talking of 14 months. By 14, then by 30, isn't it?
But it sort of works out to 2 patients a day.
That's correct. That is the actual. We compared all the patient care records. This is why we are saying there are times where there were 5 ambulances, and when the other ambulances go for service, the number can actually drop to 2. There are times when the ambulances will just break down, and there won't be any ambulance. So this is the difficulties of when we say 5 ambulances. It doesn't mean they were all running 24/7, 365. So this was once you have 5 ambulances. It means the wear and tear is just too aggressive on those vehicles because they don't stop. They are just constantly running, and when they break down, there are systems to have them serviced, which sometimes can take a week or 2 to be approved. So I would still agree that this is the actual on average, yes. So, but it means there were days that there were no conveyance at all because there were no ambulances. So when you then average, it will still come to about 2. That's correct.
Mm.
Yeah.
Because
Malusi, did you have a follow-up?
we didn't need to remove anything because that then would introduce bias in our research. We actually wanted to find out. So this is one of the findings that you are telling me that you're also recognizing, that it shows as a city, if you have 2 ambulances, what you're basically saying, if this is the correct number per day, you can actually convey 2 people.
Mm.
So you now have to ask yourself difficult questions. So what are we doing? Are we improving, or we are just being paid for nothing, or we are not doing anything, or we are harming people? Because by only conveying 2 people per day, it means what's happening to maybe other 15 or 20, because we know the calls were 300 per day at one given time. The population at that time, it was lower than 3 million. And now in 2019, the population was around 3 million. It was actually around 3 million. It means more people for fewer ambulances that are public. So it shows, research. That's why research is so arrogant. It says that it can tell you what you don't want to hear, but that is the truth on the ground. There were times when ambulances were not there. But on average, if all were functioning, they would come to 5.
Also, on that note, I just wanted to find out, I think this is just going to your patient care records, because I do know that you had to, because they are on paper, aren't they? And you had to sort of like transfer them over to soft sort of like copies in
Yes.
order to try and
Yes.
manage this data much easier. Just a side question. Did you have any system in place to sort of like evaluate the quality of your patient care records, or like what's being registered by your clinicians as a service?
Hello, can you hear me?
Yeah, I can hear you. Sorry, did you get the question?
Yes. Um, like I've already alluded to you before, we didn't have any systems in place to evaluate whether annually, biannually, quarterly. There were practically no system to look at these patient care records. And that's why I've told you that was like a huge awakening slap on me when I started to find out this is what's actually happening. So we have 200, we have 240 medics with 5 vehicles. On average, the research is telling us that over a period of 14 months, we conveyed 2 people per day. So to the decision makers, to the finance people, to the policy makers, what does that say? Do we deserve to be there as an EMS?
Need to fire people. Numbers say
Yeah.
no. But people can say that 3 ambulances have 2.
So if you look at it from a negative point of view, it shows us that we are not doing anything. But I chose to see it as an ammunition to attack. But guys, this is what's obtaining for the past 14 months with 5 ambulances. In 1996, there were 48 ambulances, and our records are showing that we're conveying 300 patients every day. Because if there are 40, let's say 40 ambulances, so on average, each ambulance would convey 6 people a day, just on average. So we have created this problem. It's a man-made problem that we've created. It's not a natural problem. By not looking at our systems, by not having systems that are responsive, by not having systems that inform us if there's a drag within the operations. So,
Okay. No, I think. Sorry, Tulani, I was just gonna say this, and I think we do appreciate that being in a role where you're under resourced, you might not have all the departments that are necessary, and I can account for that. And because I have seen EMS services that are absolutely like running on the bare minimum. And I think I have seen EMS services where there is 2 people doing the same job, and it makes you think, why are you here? The other person is technically doing the job. So I think resources have a role to play, but I think it's also very important for us to have some form of feedback mechanism within the system to say that, what we're doing, is it really beneficial or is it not beneficial? What is the quality of what we are putting out? The people that are attending to our people in the community, are they competent enough? But who defines competence if we do not have systems in place to evaluate what we are trying to serve? So I think that's important. I do know that this data is from 2018, between 2018 and 2019, but perhaps we need another follow-up study to look at what is being done and actively, having systems in place to inform what we're doing and have feedback. Because then it needs to inform. People need to be held accountable, and I think that's important for serving our people in those, especially that person in the village. We're only talking about the city. This is not even in the village. We are talking about people in the city. They should be receiving at least better, for a lack of a different word in this circumstance. So I think whoever is watching from Zim or another African country that is running on bare minimum, even though you're under resourced, I think it's important to have the bare minimum policies to make sure what you're doing, you're saving the people. And at least I can say I attended to 5 people and this is what we've done. Yeah,
to add on what Elias is saying, I was thinking when we're discussing earlier between these two segments, that I should mention, while talking to one of my colleagues who teaches research at Flinders, actually he sent me an email, James Pearson, I've mentioned him before. So he was sending a proposal to the union that we should propose that.
Sorry, Malusi, to disturb. I can hardly hear you.
Okay, can you guys hear me?
Yeah,
I can hear you.
Maybe the voice a little bit. Try that.
Okay. All right. So what I was saying is that while I was talking to that colleague of mine, while he is working at a university around, and he was recommending that we propose to the union that there is a role in the ambulance service that is a researcher role. So you have the clinical department that teaches people on how to do their skills as per the ambulance service guidelines. And then you have the operational side that is responsible for that. And then you have a research department that focuses on research. And those people are just research specialists and they focus on that. And in that way, you'll have that department working with the quality assurance department. So they take the data that is whatever that they're researching at that time, they review it, they publish the research. But then the company then works on that research to see where are the areas of improvement within the organization. So I do think that could be a very great suggestion to whoever is the head of EMS in the province, in a state, in a government, that research departments are something that we need so that they can check us as the operators, that where are our weaknesses, where should we improve? I think that's very key.
Sure. So yeah, thanks for that, Melusi. I've never thought of that, but I think it's quite a very good suggestion that, especially within the research space, because we need to be doing a lot of work in the EMS. I've got 2 questions, Doctor. And one's maybe personal, and the other one is more on your results. Okay. So the first question is related to, if you think about the 10-year tenure that you've had in Harare as the director of EMS, why did you leave? Because there's so much that you were doing that you had positive change. Why leave the system that you built from scratch, or not from scratch, but system that was non-functional? You built it to a point whereby it's functional, despite all the challenges that you've had. You mentioned COVID, you've mentioned everything that has happened, where there was a loss of ambulance services, there's infrastructure, there's also fleet challenges. Why leave the system? And the thing is, why I'm asking you is that, and I'll bring this to maybe politics, is that we've seen in politics is that people come in for 4 or 5 years. Within the 5 years, somebody else comes and then things don't go the way they're supposed to be, comes with new ideas, and then the whole system becomes messed up. So yeah, why leave? Why did he leave?
Well, you were not joking when you said you were going to ask me a personal question, right?
Very direct. Straightforward.
Okay. So from the onset, it's not like I was pushed to go to EMS. I knew there would be challenges, and I knew there will be struggles, but I've just been one person who does not run away from challenges or struggles, because I believe if you can find solution to the struggles and the challenges, then you can then term that success. That's how you impact in the community. That's how people leave footprints wherever they go and whenever they go. My predecessor spent, I think, 8 years, 10 years, 8 years, and left. He went to join London Ambulances. Then I think he's now in Australia. So it appears most people are quite nomadic. I'm talking to Tulani, who is in the Middle East. Elias is in New Zealand. And Malusi
In Australia.
You might even know your colleague that left Zimbabwe to go and work in Australia.
So I may be tempted to say being nomadic is part of the trade by the representation of the panel here, but obviously there are other reasons. I was very much motivated to dive into my challenges by leaving City Health and join the EMS department or the division, which was under the fire brigade. For me, it was an exciting time of my life. I was energetic, young. I also the other background that I left out is during my first year of medical training, I became a cadet, an army cadet, and I only resigned after 7 years after completion. Then joined the CIV. So by nature, I'm not a pushover. I'm resilient. I don't jump out when things get hot. But I still believe I don't have my work within the EMS, not just for Zimbabwe, Africa, or globally. I still think I've got a role to play. So I've never really left EMS like leaving. I may have changed the environment, but I'm still very much active in terms of what I do. In 2017, 2018, I was doing my European Master in Disaster Medicine course. So that disaster medicine course was followed by another University of Cape Town disaster medicine program that I also went through. And that allowed me, remember I was telling you about EMS being quite broad. It's emergency, but I was now focusing if the part was, I remember emergency has got 4 cycles: prevention, mitigation, response, then recovered. So I knew I was very honest with myself, because that also would allow me to manage my frustrations when resources are limited. So I had to invest more towards prevention, mitigation as part of emergency preparedness strategies, disaster medicine, all those things. So currently I'm more into consultancy with regards to business continuity strategies, preparing corporates for, to continue business even during emergency times, and also to make sure their recovery is smooth. That is what we're also now doing with the private sector, public sector during COVID. I worked with a lot of corporates, some state, some private banking institutions, in terms of helping them remain functional and survive the COVID pandemic. Because they had to be live during COVID and they had to be life during recovery. But if you don't prepare businesses to recover positively, there's going to be another disaster in terms of businesses collapsing. So we had to prepare businesses within complex times where they'll be able to recover smoothly. So that it was recovery is also part of emergency disaster management. So I focused more on the first two: prevention, mitigation, and then recovery. So during COVID, this is now the reason why I left. Are you guys hearing me, or because it's stuttering?
Yeah, sorry, the
You're
network
back
was just
now.
cutting out a little bit. Yeah, you're back now. We can hear you.
So I'll be the first one to say, after overseeing testing almost 600,000 people with 60 people over a period of 24 to 48 months, I then suffered from pandemic fatigue. I was so tired. In a week, I would spend maybe 2 days with my family. I lost colleagues. I lost close family members. My wife was constantly worried, are you going to come back alive? Because I was in the thick of things. The first COVID, I would convey returnees from abroad, would test them, decide whether they go to, COVID centers for further assessment before we discharge them into the community. Then that phase passed. We had to look for cases within the community, test them. If they needed conveying to COVID centers, we were the ones doing that. The other private players, initially they were scared, understandably, because they were not prepared. But so we undertook the process of then training. We trained about 7 to 8 private ambulance services, then assist us, because we knew we would not be able to cope with increasing numbers. We obviously had our fair share of internal critiquing, where people thought we were not doing the right thing. But at that time, there were no proper protocols anyway. We had to come up with our own protocols. I had to borrow protocols from my Italian counterpart that we had during COVID, during the disaster training. So we had to implement, develop SOPs, look at occupational safety, hazards, prevention, and control of issues. If there were any administrative issues, we worked with them. Engineering controls that needed to be improved. We did that, but we also felt the level of support was not marked. So obviously, I had to incur some personal losses in terms of lives, my relatives. But the one that was painful for me, the personal loss that I incurred, was financial. I had to look after my team of 60. Because because we were a dedicated COVID response team, the first of its kind in Zimbabwe. We had to make sure they had basics like meals. That I should have, I could have found other ways of funding their meals, but I ended up using my personal resources to feed 60 people for a year. Breakfast, lunch, those that were on duty during dinner, I would then make plans. So it happened. At that time, I was happy, interested. But when we were approaching the end, you then somehow discover maybe it's a thankless job, or it's your cross to carry. I'm proud of it. But I then had pandemic fatigue. My last gig as public figure, I was the head of medical for Zimbabwean athletic team during the African Union Sports Council in Lesotho, 2021. We were the only team that had a COVID center within a sports village. We were testing our athletes daily, isolating them when they have COVID, quarantining them, isolating them when they were symptomatic, quarantining them when they were positive. Then we had to come back. I had to come back as the head of the medical team with 14 positive clients on a charter flight back to Harare from Lesotho. Then I was also part of the COVID within the cricket team, national cricket team. I had to go into camp. So it was quite a stressful time for me. So I should be fair and say I'd burnout, COVID burnout, COVID, they say pandemic fatigue. So that's why I left. That's why I said, no, I need to focus now on my family. I've served my country. I know I'm not going to get any pat on the back that says well done. For me, I knew I just had a paradigm shift where I said, no, my army training, maybe I was waiting for this to fight for my country, to save my country. So that's what I did. And I said, no, but now time is enough. I need to be a bit selfish. So I decided to go to school to England, and I took my family with me. And that's where I've been now. At me back to sort out some papers, then hopefully we'll go back. But if there are opportunities that arise here, and if our minds are sort of like thinking in the same direction, and they think there are challenges that we can improve, definitely. I'm an EMS person. I never left EMS. I left the certain geographical specification.
Okay. All right. No, thanks, Dr. Somani. I think I want to ask the other question because we're running out of time. But what I do want to say is that I think during this podcast, you've also shown your vulnerability, that as human beings that we do go through a lot, and especially during COVID, all of us went through a lot, either financial losses, other family losses, and it was quite a traumatic time, for everyone. And how did we come out from COVID? There's lessons that were had to be learned. And look at us now. We are here sharing our stories that we've made it, and the future looks better than during those times. We never thought we would be here. I mean, I've thought also maybe I would have been killed by COVID at that time. But I'm glad that we're all alive, and sorry to everyone that lost their loved ones. But yeah, from my side, look, thank you for your time and for sharing your stories. It was insightful, very, very informative. And it was good to learn about Zim. And yeah, and just one last thing is that I know this is a silly one.
I thought Magnus was going to ask that one.
No, like the names that people come up with in Zimbabwe, where do they come from? Like metric,
Fortune. I think it's the English influence on it as well, isn't it?
That's what makes us unique, right?
True. That is absolutely correct.
Our names, they seek to largely inspire, to inspire, to make sure people are resilient. They strive to keep working hard. So you find the names are very, 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 they're English words, but they talk of a certain story. Persevere, perfect.
Mosibanda. Love Mosibanda.
Strive. The business mogul is Strive Masiwa.
Yeah.
And the name is Strive. So it shows maybe the parents are saying you need to strive every time to be successful. Strive for perfectness. Strive for the others in Shona, they talk of, be brave. Some say, don't be forgetful. Always remember, your background. So the names are serious in the nature that they are meant to remind either the people around you or yourself to be a good member in society, to be successful, to be hardworking, to be faithful. So if some are called love more, maybe around that people, they needed more love, or they're telling you need to love each other more. So, so they're good names, but if I understood, if I were quite gifted in understanding the Zulu names, and I think I would be asking the same thing.
Yeah.
I can tell you for free, if you observed during this podcast, I was the one who was most quiet, and my name is Chulan, so that's why I was quiet.
But you were charged. You were charging at the end.
Yeah, he was. Direct, straightforward, going for the jugular, actually. Dr. Soman, thank you for your time. We really appreciate you coming onto the show. We appreciate your insight once more. And I'm sure this is going to be informative for, just not us as the hosts, but also the people that watch in our community. And I'm sure for Africa at large, because people want to know what is happening in each country. And that is our motive. We want to inform, we want to educate, and we want to spread the word of what's happening in each and every country in Africa. So thank you again. For those that are watching, please do like and subscribe. Do share it with anyone else that might enjoy our content. And that's it from us. Thank you and take care.